Good afternoon, everyone, and welcome. And my apologies for the delay in starting. We had some technical difficulties, but we can get underway now. Welcome to the second session of the Hopkins In Focus online research event. Today we're focusing on citizens and communities, rights and dignity of people with disability in 2020. I'm Professor Michelle Foster, I'm Research Director of the Hopkins Centre, and I'm chairing today's session. I'd like to extend a very warm welcome to everyone who's live streaming this event across Queensland and interstate. We had almost 250 registrations for today. And a further warm welcome to our Hopkins Centre members, our partners and collaborators. Before we begin today's proceedings, I would like to respectfully acknowledge the traditional owners on the land on which we meet virtually today. I know we're all in different places, so I encourage you to know whose land it is you're meeting today. My office is on the land of the Yuggera people, and I'd like to pay my respects to the elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander people. The Hopkins Centre is proud to partner with Cisco WebEx to bringing you this event today, and I thank them for their support and sponsorship, as well as Cisco WebEx. We have Telka and VBRIC also supporting this online event, and so completing that virtual interactive experience for us. Some quick housekeeping before we get underway. In the online environment, we have some caption capability in the VBRIC system. So that capability button's located on the bottom right toolbar, and if you click that button, you should be able to enable closed captions, and then select English and then see the subtitles under the live event. If you have any difficulties at any time, you can always pop a question into the Q&A, or you could email one of our support staff, our event staff at hopkinscentre@griffith.edu.au. We're hoping to have opportunity for Q&A. Depending on how we're going with time, we have got a very packed program. So I'll ask you to submit questions into the Q&A section, and that's the right side of your screen. You'll see the little blue question mark icon, so you can pop your questions in there. They will be viewable to the audience. If we have time and speakers have time, we'll endeavour to answer those questions. But we are recording this event, and we will forward the recorded session in the coming days, and with responses to questions and any other related material. So the Hopkins In Focus series has been designed to bring you a range of perspectives and stories about the disruption of 2020, so that we can learn about the impacts, but also the responses of our rehabilitation systems, services and communities. And each session showcases a different perspective on disruption and adaptation. So this is the second session, as I said, so I'd encourage you to register for our final session on our website, and I'll tell you a little bit more about that later. But today's session is bringing you perspectives of citizens with lived experience, industry and advocates about the impacts of 2020, highlighting the voice, the connections and the communities for resilience and responses. And pending time, after our invited speakers, I'm hoping we're able to share with you an inspiring new initiative, which is the Citizen Challenge Initiative, and I'll talk about that a little bit later. So to get underway, today's session is particularly pertinent as it's Human Rights Month 2020 for Queensland. And that concludes with the International Human Rights on the 10th of December. But also because Queensland now has the Human Rights Act 2019, which came into effect on 1st of January 2020. And on that note, it's my pleasure to introduce our first speaker and one of Australia's leading advocates for people with a disability, Mr. Kevin Cox, AM, Honorary Doctorate of Griffith University, and patron for the Hopkins Centre. Kevin is also Executive General Manager of the Integrated Accessible Transport Network for the Department of Transport and Main Roads. Kevin's address to us today relates to the citizens' rights and dignity, and how to safeguard and promote the rights of people living with disability. Thank you, Kevin.
Once again, I'm deeply honoured to be asked to speak at the Hopkins Centre Symposium. This symposium is critical in creating a space where frank and fearless conversations can be had to make the world a better place for people with disability to live their lives with dignity and free from discrimination and receiving health and rehabilitation services in Queensland and Australia. I too acknowledge the traditional owners on the land that we meet, the Jagera and Turrbal people, and I pay my respects to the elders past, present and emerging. Additionally, in acknowledging the oldest living culture, I also acknowledge their wisdom in the use of science, medicines, land management and preservation of the land in order for all species of life's survival. I've been asked to briefly speak to whether people with disabilities' human rights are being respected, protected and fulfilled by the state in situations of risk and humanitarian emergencies, which is Article 11 of the CRPD, and it's an extension of Article 10, the right to life. Article 1 sets out the purpose of the CRPD, and in particular, it requires the state 3 levels of obligation: promote, protect, and enable the realisation of the human rights and fundamental freedoms of persons with disability. The article also requires state parties to promote and respect inherent human dignity, which is the ultimate source of all human rights and freedoms. Firstly, I'm just going to talk about the CRPD's committee assessment of Australia's compliance to Article 11. For those of you who do not understand the workings of the UN, every 4 years, Australia has to provide a report on how they are meeting the treaty that they are signatories to. And Australia is signature to 17 conventions, and the CRPD is the last one. So in the sense of the compliance to Article 11, I'm taking a brief summary from a research report commissioned by the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability. This document was written by Emeritus Professor Ron McCallum, the inaugural chair of the CRPD committee, a great Australian with a disability. In February 2009, 2 years after Australia ratified the CRPD, the Victorian bushfires and their subsequent inquiries alerted Australian governments to the necessity of considering persons with disabilities and other vulnerable groups when planning responses to disaster situations. The development of appropriate plans and response took some time. In 2013, the CRPD committee's concluding observations expressed concern that disability had not been factored into Australia's local, state and national emergency plans and recommended that it establish national consistent emergency management standards in consultations with persons with disabilities. In its combined second and third periodic reports of September 2018, Australia noted that its national strategy for disaster resilience was endorsed by the Council of Australia Governments, COAG, in February 2011 and was relevant to the strategy being implemented in a nationally consistent way. Australia also wrote it had recently established a National Resilience Task Force to develop a new 5-year disaster mitigation framework for Australia. This new framework will be guided by the Sendai framework, including as it relates to persons with disability. The Australian Human Rights Commission observed in 2019 that these provisions are not yet in place. In June 2018, the National Resilience Task Force held a 3-day meeting with members of all levels of government, business and the community to develop a national disaster risk reduction framework. Effectively, a roadmap of actions to be taken from 2019 to 2023 and is designed to guide Australia in reducing risks that flow from disasters for its citizens. It is concerning that the NDRRF fails to mention disability. This is not surprising, as the first 2 sections of the Sendai framework do not address a disability. However, the 3rd section does. The 3rd section was then delegated to the Australian Disaster Preparedness Framework, which was developed by the Australian Government in consultation with state and territory governments. The ADPF is a high-level strategy document which leaves many of the details of disaster recovery to the state and territory governments. Persons with disabilities are only mentioned once, under discussion of mass care, the ability to meet essential needs and provide care to high volumes of affected citizens, both in and away from impacted areas. This includes, but is not limited to, health, psychological, aged, pharmaceutical and disability care. This limited mention is disappointing and limits recognition of disability to the context of health, rather than a consideration in integrated throughout disaster preparation and response policies of all governments at all levels. Professor McCallum concludes in this chapter that it is clear that Australia is working to ensure that its people are protected and cared for when disaster occurs. However, persons with disabilities and their representative organisations have not been adequately dealt with or considered or included in planning thus far in this area as required under the CRPD. The most recent Royal Commission in the 2019-2020 bushfires presented an opportunity to provide further comment on Article 11. However, the letters patent do not make any reference to disability. To tell you a couple of stories that have been presented to highlight how people with disability have been treated in the pandemic. The Brisbane Times on October 11th reported in a recent 4-day hearing of the Disability Royal Commission, it revealed the terrible toll the pandemic has taken on people with disability. The picture that emerged from the hearing is of a nation divided in the treatment of its citizens in time of emergency. Too many have been left to fend for themselves in frightening and unprecedented circumstances. The hearing took evidence from 36 witnesses, many of whom are people with severe disability. Witnesses spoke of the sudden loss of support services essential to daily life, lack of access to basic necessities such as food and medication, and uncertainty about the prospects for survival in the face of prolonged disruptions to essential care and support. Witnesses told of other harrowing experiences, extreme stress and anxiety caused by the potential exposure to the virus through contact with different casual support staff coming in on a daily basis, if they came at all, the lack of personal protective equipment, both for the person with disability and support staff. Some witnesses expressed a fear that people with disability would be given a low priority for access to life-saving treatment or care simply because of their disability. This fear was part of a more general theme that people with disability feel devalued. Witnesses explained that some language that is widely used makes them feel that they are regarded as a burden. And as a burden on the community. Disrupting commentary on social media conveys a message that COVID-19 is about survival of the fittest, and that the fittest do not include people with disability. That was quoted in the Brisbane Times. I share this fear based on my professional and personal anecdotal experiences of my advocacy for vulnerable people over 20 years, and being a member of the team of the Public Advocacy Report, Upholding the Right to Life and Health, a review of the deaths in care of people with disability in Queensland, 2016. Many of those deaths were very preventable. The following case study of a witness at a recent Royal Commission hearing reinforces that Australia is still failing to respect and protect and fulfil persons with disability as articulated in Article 10 and 11. A disabled woman had caught COVID-19 from a support worker after the National Disability Insurance Agency refused to allow her sister to provide care instead during the pandemic. The woman's sister, I will refer to as a witness from here on, told the Commission that her sister's mental state had rapidly declined after being without care for almost a month as a result of the decision. The witness also is a professional support worker. She reapplied again in August, following her fears for her sister's safety and mental health. The requested was denied. The witness said her sister, who lived alone in Melbourne's inner north, was aged in her 40s, never would have caught the virus if the NDIA had approved her application. An NDIA spokesperson said the agency had a range of measures in place to ensure the well-being of participants during the pandemic. While we recognise the challenges of the coronavirus, funding of family members to provide paid support is not agreed except under very exceptional circumstances. Usually only where all other suitable support options have been exhausted, he said. Her sister now has been without formal care since July 24, while her support worker, who she had a close bond with and trust, had been in intensive care. This is a clear case that demonstrates Australia is still failing to fulfil its obligations to respect, protect and fulfil persons with disabilities' human rights. If in a pandemic, I cannot see how this wasn't an exceptional circumstance. Thank you very much.
Thank you, Kevin. You always manage to provoke us to think about our obligations. So I really appreciate you giving us that overview. I think we can see that there's been a lot of incremental kind of movements towards promoting and protecting the rights of people with disability. But certainly the pandemic has exposed our shortcomings in policy and in legislation and in rights frameworks. But what does it tell us or teach us in terms of the direction to make sure we are recognising the rights of people, Kevin?
I think it just highlights, as I say, that by just briefly summarising how well Australia has complied with the CRPD since 2009 in situations of emergencies, man-made or natural disasters, and of course no one predicted the pandemic. It basically, I think it's quite compelling. People with disabilities are still being left behind when it comes to these obligations the government have signed up to in the convention, and they have not even engaged the disability persons organisations or people with disabilities in these processes. They engaged business, they engaged other entities, but not some of the most vulnerable citizens and people with disabilities included in that. And I think as a state, a nation state, it has to be better, and we are better than that. But consecutive governments have continued to fail people with disabilities, and I'm not optimistic that it's going to improve rapidly. Particularly when you have the Human Rights Commission, the Australian Human Rights Commission, calling out the government for not implementing something they had said they had done into the convention at Geneva reporting process.
Well, thank you, Kevin. Thank you very much for your time and your inspiring words. And I think you've laid down a challenge, and perhaps our next speaker can assist us with that. So thank you very much, Kevin.
Thank you.
Our next speaker is Michelle Moss. Michelle is Director of Policy and Strategic Engagement at Queenslanders with Disability Network. And consistent with QDN's objective to give strong voice to citizens with disability, Michelle's presentation today addresses consumers' perspectives and responses during COVID-19 this year. Thank you, Michelle.
Good afternoon, everybody, and it's my great honour to be here this afternoon to present about the land on which we meet and people. So, for, I guess, giving that contextualisation about people's rights, particularly around emergency and disaster preparedness, and also what that has meant in the pandemic and this year of disruption and presentation today. Need for advocacy and the rights of people with disability. And I think this afternoon I wanted to share with you some of the stories of the strong voice of Queenslanders with disability and the leadership that people in the challenges of we have a statewide network of members who are all people with disability, and we're almost heading up towards our 20-year of operation. And I'm pleased to let people know that one of the important pieces of work that we've been doing over the last year has been around disability reduction, and I'm going to talk a little bit about how that all fits into the story of disruption and adaptation and resilience during COVID. So Kevin was talking about, I think, some of the things that we really of the impacts experiencing issue, but to be able to be connected. As providers connecting to health services, and even that basic human right and connection with others. We all weren't allowed for a walk, and interpretations of the directions, still having to go to we heard stories people who had not meant for them. The different things that they experienced in the COVID environment, and the financial impacts as well. We heard lots of stories from people about, not basic things. At the same time, we were seeing from the system, and what we saw from the system was some of that stuff that we know to be those for many, many decades. And we saw that lack of local and national coordination across disability and health start to really ability of having health, not having that good understanding of disability. We saw lots of local providers with the chief officer of what they meant. We saw the challenges around how defining essential services and what's essential for a person access to those essential disability services, which at the end of saw some of that inflexibility of systems we work on. And I think, as Michelle was talking about earlier, it really shone a light on all of those. I think at the same time, what we saw in that dance between disruption and adaptation, between chaos and I think it was not range of work of health and disability, working collaboratively together. At the systems level, to bring departments of and communities and disability and stations all be able to design what those solutions are. So I think the key and those challenges around respond and recover at the same point in time. But I think at the heart of it were the rights of people with disability. And we heard the big picture issues and some of those solutions that enable people with disability to have information that they needed, to have the support that they needed, and to have the system responding in the way that was needed to ensure people could access services, could access what they needed. So early on, it's really important that people can get the facts, that they can make a plan and stay connected. To include disaster risk reduction and with Community Services Industry Alliance, it's been funded by the Department of Communities to ensure that people with disability aren't left behind in disaster preparedness and disaster planning. So local support group to online. And that was really important as a way of being able to stay connected to them. Connected to each other and support, but also advisory with disability about what the has in the developing sources for disability, emergency preparedness in our work with the lots of words for an individualised planning tool for people about the 8 different areas of life that they need to consider, all the different aspects, make a plan. And resources. And it's a wonderful thing for people to be able to feel empowered to have been included as part of the design of that, and actually is to have that tool, because we know that COVID has been a game changer for all of us, but certainly people with disability. Worked to look at that digital divide and worked with Give It to get devices for people. So we were able to get devices and people who rights in health is also a really important issue. Sort out getting we also to make some user friendly around the chat. It's important to build the capacity of people with disability and what's happening. It's about held a series of actions and disability service providers, people with disability were making sure that they could have during the so I think that Kitty and Small disability, and that they've been allowed in about what the impacts are, what is solution. There's been a range of work that CUT members have done to inform lots of those things that are listed on that people with disability. So Michelle, I'll hand back.
Well, thank you very much, Michelle. And it's really interesting to see what the range of things that can come from good collaboration and inclusiveness of people with disabilities. So that's, there is one question in our chat, so keep questions coming into that chat if you have questions for speakers. But the question is, what are ways that services and staff can actually support people with disability to be prepared for emergencies and to make a plan.
Thanks, Michelle. I think one of the really practical ways that services and organisations can support people is to work with the person around their COVID plan, that COVID-19 person-centred emergency preparedness tool, and for broader emergencies. And I'm happy to share that and the links with people to support people on that process. It's not something that you can do to sit down and go through it all in one go, but it's a conversation. And one of the things that staff and people in people's lives can do is to begin that conversation with people and support them to work through those key areas and help them make a plan, because our members have said that helps people start from a place of hope and not fear, because they're empowered and have some clear things in place of what they can do.
Thanks, Michelle. And that's great to know that there's access to some really practical resources. So thank you again for sharing those insights with us today. So our next speaker, I'd like to introduce Mr. Cole McAreath, who's a peer support leader at Spinal Life Australia, where he shares his experience with newly injured patients at Princess Alexandra Hospital. Cole is also a motivational speaker, a thought mentor and an author. So it's my pleasure to welcome Cole to share his experiences and insights about how people with spinal cord injury have been impacted, but more importantly, how they are responding and adapting in 2020 through connections and communities. Thanks, Cole.
Thanks, Michelle. My work in the spinal unit, the peer support program in the spinal unit started about 15 years ago through an identified need for people in the spinal unit to be able to give themselves a new vision of what their future might look like. And when you first have a spinal injury and you hit the spinal unit, it's like all your future has been erased, and it's very difficult for people to see a positive future. And most people come into the spinal unit with their minds and their thought processes very much focused on what they can't do and what they've lost in the past. So the role of the peer support program is to show patients and their family members what life can still has to offer. And the way that we do that is by sharing our own lived experience. The team consists of myself, Katie Hammond, and now we've just included Tim McCullum on the team. So between us, we have a lived experience with spinal cord injury of over 90 years. So we spend a lot of our time sharing our lived experience with patients and just telling our stories and modelling what we're able to achieve. And a really good example of that is just driving into the spinal unit and parking in the car park beside the unit, getting your wheelchair out of the car and transferring out of the car to come up into the unit. And people will watch us do what we're doing, and you can see their brains kind of ticking over and thinking that that's something that they'll be able to do just simply by seeing someone else do it. Our message is very powerful in that it's coming from somebody that's lived through the experience of having the spinal cord injury and coming through the rehabilitation program. We pride ourselves in the fact that we're constantly trying to come up with new and innovative ways to share that lived experience. And one of the ways that we came up to do that was to set up a social media group, which we did, that will give people access to not only our peer support team's lived experience, but also the lived experience of all the members of that group. And we have now over 2,000 members in that peer support group sharing their lived experience. So probably for that first 15 years while we were delivering our peer support in the spinal unit, we never really envisaged, is that a word? We never really thought that we would be in a situation where we would have to provide support without actually being on the ward. All of our ways that we shared our lived experience involved face-to-face conversations with patients on the ward. We're involved in the therapy groups, in occupational therapy and physio. We play a part in the patient education system, in consultation with the nursing department. We attend the patient forums. We attend the Wednesday afternoon sport and rec programs. We would get involved in fun days, dress-up days, things like Melbourne Cup, where we get dressed up in our finest race going gear. And again, just to model to patients that these were things that were still possibilities, and to kind of reinforce that you don't have to wear your hospital jammies and your tracky-dacks all day. You can get dressed up in your suit, and Katie would put the heels on. And that visual connection we thought was vital in our ability to provide peer support. And then along came COVID-19, and all of a sudden we were denied access to the spinal unit. And the patients all of a sudden had no peer support program, no one to look towards to see what their life could look like. And the effect on them was quite significant in that not only were we excluded from the spinal unit, but visitors as well. And while our job is to share our lived experience and to validate, I guess, where patients are at that point in their life and in their rehabilitation, I can't imagine how I would have felt if I was trying to do that without the support of family and friends. And we did see some patients that were really significantly affected, and the flow-on effect that had on their physical rehabilitation as well. And we noticed how quite a few of the patients wouldn't engage in their physical rehabilitation because of the fact that they didn't have that support emotionally from their friends and family and from the peer support team. So we had to quite quickly come up with some plans on how we could still provide that support to people. And I like to think that we came up with some pretty good plans. And one of those plans, we obviously resorted to technology, and through the help of some of the staff members to communicate with patients how they could get in touch with us. But one of the plans that we came up with was to text us a question and we would reply with a video. So during the lockdown, the first lockdown phase of COVID, we were doing just that, and patients would text us a question, and one of the three peer support members would go and put together a video and either message that to them so that they could then get an answer for their question. With the social media group that we already had established, we promoted that group and we started to do regular, we call them Ask Us Anything sections, where we actually went live on the social media, promoted that live event, and people could then watch us discuss whatever the topic of the day was. And the very first one was around COVID and around some of the things that we were doing in our own personal lives to help us to get through COVID and to get through that isolation and problem solve the things like, how do you get your groceries? How do you communicate with your medical team? All of the things that impacted everybody, but had an extra complication when it comes to people with a spinal cord injury. So that was very well received, and we've now since done, I think, 4 or 5 of those online events. We were allowed back into the unit after the first lockdown period, so we quickly tried to set up put some systems in place that would help us if and when we would be denied access to the unit again. So unfortunately, that came a lot quicker than we'd anticipated. But what we did manage to do was to set up a separate social media group specifically for patients and family members that were currently in hospital. And we found that the needs of the people while they're in hospital were quite different to the needs of people out in the community. And also some of the responses that were given in the community group may not have been the responses that someone with a newly acquired injury was quite ready for. So we set up the new, very much invitation only social media group so that we could communicate directly with patients in the unit and their family members. One of the issues that we had with trying to provide our support via technology was the fact that there were no helpers in the spinal unit. Patients, family members and friends provided so much assistance. And then all of a sudden, when those people were not allowed into the spinal unit, those tasks then fell on the staff members, the nursing staff and the allied health staff, to provide the support that family members had been providing. Simple things like helping with meals, doing little bits of shopping, washing clothes, that all fell on the staff members as well. So everybody was under the pump, and I know that there was quite a bit of tension and stress across the whole ward, especially during the second lockdown period, to the point where one particular patient was about to do a hunger strike until he got access to his family members. But luckily that was averted. Now we're back in the unit again, and we're trying very hard to make sure that we get the connections with the patients and we get them connected up with our community and with the technology that hopefully in the future, if and when there's another lockdown period, we can still provide that support to people. So I think that's about it for me at this stage. But if there are any questions, I'm happy to answer them. Our catchphrase with peer support program is, if you're going to ask, we're going to answer. So if any of the audience today have questions, I'm happy to answer. So fire away.
Thanks very much, Cole. And it's good to be reminded of the challenges that people who are actually inpatients in hospital were going through. And it sounds like you were creating some really new ways to try and keep that support going, which is fantastic to hear about. I did have a question that's been posted. What did you notice about the change or the increase in mental health issues for people during the COVID time? What have you noticed?
Look, it had a serious impact on lots of patients. The main one being that disconnection from their family, the loss of physical contact with family. I mean, it's a lot different to speak to your partner or your children on the phone, or even a video hook, than it is to actually have them there. And one patient in particular I know, who was from rural Queensland, had not had any contact with his kids for 4 months. And I can't imagine what that would be like. And I was actually on ward the day that his kids arrived for the first time, and I think they spent the first 10 minutes just crying in a family group. So, you know, it had a huge effect on a lot of people, and I don't know whether it's related or not, but we've had quite a few people that have recently discharged that have had some significant mental health issues, to the point where there have been suicide attempts. So I will never know whether they're related to their coming to terms with their injury, but I'm sure that the complications of COVID would have added to that. So it has had a little bit of a silver lining for us, in that it's highlighted some areas that maybe we needed to improve as a service, because we didn't actually have a contingency plan in place to say, okay, what if you can't go into the unit? How are you going to provide the support? And now we've got some better ideas to do that, and we'll hopefully work on them, on refining those into the future.
Yes, well, thanks very much, Cole. It certainly is a very wonderful service that's provided and has been provided for a long time, and obviously very adaptive in this time. So thank you very much for your time and for sharing that with us today. If anyone has more questions for Cole, don't forget to post them, because he can respond to them afterwards. So thanks, Cole. We'll move on to our next speaker, and that's Dr. David Rowland. David is a writer, speaker, psychologist and honorary associate with the University Centre for Rural Health at University of Sydney. David has written his own memoir, I Rescued My Brain, about recovery from stroke and trauma. And today he talks to us about solution-focused positive resilience and how individuals with disability can respond and take control during times of disruption. Thank you, David.
Cool challenges. Hello, everyone. Well, I want to talk about what it's like when we hit major disruption, when some life event happens that turns the way we were living or the world that we live in upside down, so that our life story that we had is no longer the life story that seems possible now. The human brain has this amazing ability to time travel, much more than any other animal species. That allows us to dip into the past, into our memories, and bring them into the present. And we create a story of how we've come to be the sort of person that we are, the way the world works, and our value in the world. And we project that into the future. So we create this future self, or this future life story. So when disruption comes along, what it does is it actually dismantles our story itself. It says, no, the story you had about yourself, the future that you were projecting, is not the future as it is. And so the despair or the fatigue or even the great distress we might experience when disruption happens is actually our story itself being dismantled and being remade. And we need to think about, when disruption happens, there's three motivational or emotional systems that are in play here. And after disruption, the two that tend to get more exaggerated are the drive system, which is about getting ahead, getting food, shelter, safety, those sorts of things, or more toilet paper if we need that. The second one is the threat system, which activates the fight-flight response. So we tend to be much more on alert and more worried about our safety. Now, we do need both those systems, but in the aftermath of disruption, when we've done all the practical things that need to be done to keep us safe and provide the supplies that we might need to live, it's really the third system that became highly evolved in mammals, especially humans, that we need to cultivate more. And that's called various things like the soothing affiliation system, the caregiving system, the rest or digest system, or the tend and befriend system. And the way to cultivate this is through soothing. So that can be anything from, having warm baths, touch, breathing exercises, doing meditation, any type of relaxation, listening to nature sounds, being in nature, or connecting with loved ones. So we want to do things that help us to soothe. And most of us know already those sorts of things, but we need to consciously do them more and turn off the things that will activate our threat system and probably let go a bit of the drive system. And even during this aftermath period, it can feel like there's a solid wall of despair or uncertainty or distress, a bit like what Cole was talking about when people come into the spinal unit. But in fact, there will be moments when there's a sense of relief or a sense of lightness or even moments of joy. And so we want to notice those things and notice what brings them about and then cultivate them. The other thing we really want to do is any form of physical activity we can do just to deflate the effects of that fight-flight response and also increase our sense of well-being. But we also want to cultivate self-disclosure. Cole was talking about the effect of when self-disclosure or connection with others is taken away. So self-disclosure can be writing things out, how I'm feeling, what sensations I'm experiencing. It could be done in writing, or it could be done through the expressive arts, or in any other medium where it feels like you're unloading some of those heavy thoughts and feelings. But it also can be hearing other people's stories. So even listening to my story now and Cole's story before, we're actually connecting and sharing our stories. And when we listen to somebody else's story, we're helping them connect with us. And when we tell them our story, we're helping them connect with us. So we need to find ways in which we connect with others and share our stories. And of course, during times like COVID, where there's various restrictions, we come up with new ways of doing that, just as Cole was illustrating earlier. But we never want to give up hope. Hope is a real thing. So when it feels like nothing is changing, we still want to hold on to hope. And hope simply means that this is probably not going to be the way it stays, that there has to be some other way that this will go, even when we can't see that. And time again, we've seen people who've been through the most amazingly difficult life challenges, and they've just been hanging on to hope, waiting for something new to happen, some new person to appear, or some new insight to occur. So hope is a real thing. What I've discovered when I did my recent investigation into human suffering, which I've written up in my new book, The Power of Suffering, Growing Through Life Crises, is that there's various stages that people go through when there's a life upending event, whether it leads to disability or some form of loss. And in the immediate aftermath, there's a lot of intrusive rumination, and that can be thoughts and images, sensations, and they seem to be inserted into us without our wanting them to be there or without any sense of control. And this is actually perfectly normal and quite natural. It shows that you're a human being with a brain that's working. And what starts to change then is when we start to taste this idea of acceptance, that things have really changed and this seems to be how it is now. Like, we don't know how long it's going to go for, but we say this is how it is now. And we start to reflect on what that means when this new reality is here and it seems to be staying at least for the foreseeable future. Now, acceptance isn't something we suddenly wake up with one morning and we have complete acceptance of this new reality. It's something that tends to come with a long tail. So each morning we wake up and say, oh, yes, this is how it is now, I forgot. And after time, we start reflecting on this new reality and what it might mean for us. So we gain some new ideas or insights about what that means for us. And then we start to think in a more directive or more deliberate kind of way. So we start taking new actions. And Cole gave some excellent examples of that. like how do we connect with others when we can't be physically there in the spinal unit? How do those that are still in patients connect with their family and with their mentors and helpers? So we start to have this more deliberate way of thinking. Now, I want to tell you that I identify as somebody with a disability, primarily from a brain injury 11 years ago. And I know what it's like to have limitations placed upon me that weren't there before, to have that feeling of restriction where I don't seem to fit into the world the way it is, or the world doesn't fit into me the way I am. And so I know what it's like to make adjustments, to find new ways forward. But in my investigation into human suffering and major loss, everybody experienced that. But some of the things that they did was start to not focus on the loss, what you've lost, but what you still have, being more grateful for what I have, what is still in place, and also what the new opportunities might be, the new possibilities. It's that old cliche, when one door closes, another door opens. And we also start to notice that when we've been through disability and some major upheaval, survived that and probably grown in positive ways as a result, when we've done that, we can look back at past challenges that we've been through and know that we've got the courage, we've got the mental steel to get through that, so I can get through this. And we can draw on strategies that we used in the past and apply them to this present new reality. So in fact, what I want to suggest to you is that those of us who've experienced disability and have arrived at this new way of living, or this new way of being, or this new way of behaving, this new way of thinking, actually have a lot to offer to everyone, that we have developed a kind of wisdom or an understanding or an insights, strategies, a sort of can-do attitude, which we can share with others. Now, it's often the case that people, after going through major life challenges, develop in spiritual ways, and my simple definition of that is less of a focus on the I and a bigger focus on the we. How can I contribute to the we? Now, I want to tell you about my most favorite tree. This is my post-traumatic growth tree. And hopefully here is the tree. Now you may think it's not a particularly impressive looking tree, and that would be right, except we've got to look at the context in which this tree is at. I went camping a few years ago out at the West Macdonald Ranges, and I climbed up this hill. It's actually quite a big hill, and this was the only tree growing on that hill. And when I went up close to it, all the leaves have been little bits of chewing from insects. And this tree just seemed to be thriving in spite of the fact it's not on a watercourse. It's the only tree around that's on top of the hill, and these insects seem to be biting it. If we could see the next photograph, and this is what that tree was seeing, you'll see that all the other trees down on that watercourse, which was dry, obviously when we were camping there, are much bigger and healthier, more branches, more leaves. But what they lack is that they can't see what my post-traumatic growth tree can see. They will never get the view or the insights or the understanding that the trees down in the valley have. They will never get that. So this tree was the only tree that I could see on the complete 360-degree horizon that was growing on a hilltop. It shouldn't be there, and yet it was. And yet it was thriving in its own kind of way. So my message really is to hold on to hope, survive the immediate aftermath of whatever life upheaval it is. Things will change, find the moments of joy, share your stories with others, hear other people's stories, whether it's through movies, it's through books. It doesn't have to be the same kind of story as yours, but know that it's possible to get through major upheavals because you've probably done it already. And so you've got the courage and the capacity, and really what we now know and call resilience, to get through, and not only get through, but to grow in new and exciting ways. Thank you.
Well, thank you, David. And it's really continuing our theme today about listening to the voices of diverse voices and different stories and what we can learn from that. We've got a couple of questions. We might have time for at least one. How do you think we can best support someone going through crisis, particularly a crisis where responses have to be pretty immediate in terms of providing that hope and solutions? What's your sort of experience of that?
Well, I've got a lot of experience with that now, but I particularly like the story of Paul McFarlane. He's the senior chaplain of the New South Wales Ambulance Service, and he's one of the people that I researched for my new book, The Power of Suffering. And he explained a few things to me, and that is he goes into crisis situations sometimes after the death of a child or a motor vehicle accident scene or a suicide. And he says initially, we just want to obviously keep people safe, keep them out of harm's way. But he said, the thing is, there's nothing to be fixed. We don't need to go in there, suddenly think, I've got to fix this situation. When there's some major tragedy happen or upheaval, we may not be able to fix it at that moment. And we may not be able to find any new meaning or any new way of progressing from there. So really what we provide in that emergency situation after the practical needs are met is simply our human presence. And he said, sometimes I will sit in the lounge room with parents whose child has died. The paramedics are doing all their thing, but nobody's sitting with the parents. Nobody's sitting in that really hard emotional space. He says, I'll sit on the lounge with them. They'll offer me a cup of tea. We'll have a cup of tea. They may have some questions. They may just want to say whatever they want to say. He says, I just listen. I don't have any judgments about what they should be thinking and feeling. And then after that's happened, maybe a couple of hours, then other family and friends start to arrive. They say, they'll thank me. They'll say, thank you so much for what you gave us tonight. And he'll say, I don't really know what I gave, but whatever it was simply my human presence, my non-judgment, and my listening.
Yeah, and it's also a reminder that the support networks are really important for people too, and we have to be mindful of that. Well, thank you very much, David. And I also, again, encourage people who've got questions. You can still post those questions and we'll send them on to David and get his response. And the responses will be sent with the recording. So thanks again, David, for joining us.
Thank you, Michelle. It's been a pleasure.
All right, so before we feature our Citizens Challenge, we have a final invited speaker today, and that's Kelsey Chapman. So Kelsey's a research fellow in the Hopkins Centre, and she's the lead of Dignity, our flagship project. Kelsey specialises in disability and rights research, and today Kelsey's presentation focuses on the Dignity project and the importance of citizens' data to understand and develop appropriate responses to the pandemic. So thank you, Kelsey.
Thanks, Michelle, for having me today, and thank you to everyone who has presented before me. I feel really honored to be included in this group. So, as Michelle said, today I'm going to be presenting about the Dignity Project before, during, and after COVID-19. Before I begin my presentation today, I would like to acknowledge the traditional owners of the land on which we meet virtually today. My personal office is on the land of the Bundjalung people, and I would like to pay my respects to the elders past, present, and emerging. In accordance with the Dignity Project values and commitment statement, I would also like to acknowledge that I will be using person-first language in my presentation today. However, the Dignity Project recognizes that language plays an influential part in forming people's perceptions and identities, and we recognize and uphold each individual's right to self-identify the language and terminology that is best for them. I'd also like to acknowledge my very esteemed colleagues who work with me on the Dignity Project, including our citizen researchers, Angel Dixon, Kevin Cox, who you heard from before, and Joe Pimenter. You will now be seeing on your screen the Dignity Project Citizen Science Framework, and I just want to give you a little bit of background on our research. The Dignity Project is a research and community building agenda aimed at disrupting stereotypes and the barriers to inclusion and participation for people with disability. Using a novel approach to citizen science, which we're currently piloting in our research team across a number of research initiatives, the Dignity Project strives to move beyond emancipatory and participatory types of research towards research that embeds and privileges the perspectives of lived experience with disability within the research team and at all phases of our research. At the intersection between human experience and research, the Dignity Project uses a digital engagement platform called the Community Hub, where people with disability can share, reinterpret, and analyze their collective experiences. This private group is run by people with disability for people with disability and strives to generate research, service, and system innovations that are most wanted by the community. So prior to COVID-19, the vision for the Dignity Project was to establish the fundamental importance of conducting research about dignity for people with disability. And we knew that it was significant in a local, national, and international context as countries strive to meet their human rights imperatives in relation to the UN CRPD. We also were looking for a transparent and two-way mechanism for collaboration and communication, where we could gather and uncover citizen-level qualitative data, which is where the Community Hub and our values and commitment statement emerged from. We then designed and launched our first pilot survey, and this is in the during COVID period because we launched it right as stay-at-home restrictions emerged around Australia. So it was a very interesting time. What emerged from this first survey was really useful and insightful perspectives about dignity for people with disability, including the physical and mental health benefits of dignity, which result in people feeling happy, safe, valued, recognized, and respected. In a health context, feeling dignified increases adherence to treatment protocols and helps improve overall outcomes. Conversely, a loss of dignity and undignified treatment can have really severe consequences, including feeling less human, less capable, less worthy, and an overall increased physical suffering, isolation, and poor health. Acknowledgement emerged as a key primary theme in relation to dignity, particularly as it related to employment. Our pilot survey respondents reported experiencing greater levels of dignity when they were meaningfully employed. Yet employment was also one of the key systems in which people with disability experience frequent high levels of indignity and a lack of acknowledgement. And really interestingly, the majority of our survey participants were actually unemployed at the time of completing the pilot survey. So what did we discuss and uncover during COVID-19? Our understanding of dignity started to intersect with the actual realities of the COVID-19 pandemic, both of which we could see impacting on people with disabilities' mental health, access to medical treatment, and their employment opportunities. Similarly to our vision for the need to collect citizen-based data about dignity, COVID-19 also highlighted the lack of citizen-level data and citizen-driven data on the lived experience of disability and emergency situations like pandemic. Following the release of some forums within our Community Hub and feedback from within our community, from our community members, there was a call for a program of work around COVID-19 and a way for people in the Community Hub to share their experiences. So we designed and launched our COVID-19 impact survey. This was a deviation, I'll just go back for a second. This was a deviation from our original plan, our original conceptualization for the research arm, and presented a challenge because we were scoping out this work on the fly. A lot of our research team was in ongoing isolation due to increased health risks, but it really reinforced to us the importance of the Community Hub and systems like it for synthesizing individual perspectives into a collective experience in order to form research. So we actually recently closed that COVID-19 survey like last week or 2 weeks ago, and we are working on analyzing the qualitative and quantitative data. We're really excited to share some of that with you today. I wanted to highlight what's up on our screen now. We experimented with using Microsoft Power BI dashboards as a tool to assist us in analyzing the data in real time, but also in sharing this data back to our Community Hub members, our research participants, and now today with you all, which is an important step in our citizen science framework. The following slides that we'll look at are graphs and word maps generated directly from the survey data, and it was automatically populated into these forms. As you might expect, because of the realities of COVID-19, participants who identified as having a mental health impairment had the most negative view of the impact of the pandemic. These participants reported the highest levels of dangerous impact on emotional well-being, their ability to work, and on financial situations. And that's the graph you're looking at right now. They also reported major impact on their access to medical treatment, social interactions, independence, and the quality of their familial relationships. Participants with hidden disabilities also reported higher rates of negative impact, with dangerous levels of impact on their emotional well-being, financial situation, access to medical treatment, and social interactions, and major impact reported on their ability to work and access to transportation. Because employment is something we are exploring quite in depth following the findings of our pilot survey, we did examine employment specifically in the COVID-19 context. We found there was little overall reported negative impact for people with disability who were not employed prior to the outbreak of the pandemic, and same for full-time employees. Participants who were casually employed at the onset of the pandemic reported the highest levels of negative impact. 75% of casually employed participants experienced a reduction of working hours, and 100% of our participants who were casually employed were female, 80% of whom had a bachelor's or a master's degree. And all categories except for personal care were identified as having been impacted dangerously or majorly in a negative way as a result of COVID-19. This is that word map I mentioned that's currently on your screen, which was generated from a question asking participants about their greatest concerns during and after COVID-19. And this also was from a Power BI dashboard. Some of the key barriers and enablers to dignity began to emerge from the COVID-19 impact survey, including fear about not being able to access life-saving health services because of a perceived bias on quality of life, the quality of the accessibility or lack thereof in technology and telehealth, the recognition or lack thereof around contribution of people with disability, and this perception of burden or quality of life during economic austerity. For the more than 1 billion people who are estimated to live with disability globally, times of austerity do escalate inequality, and the struggle for a fair and more inclusive global society becomes more difficult. Disability and economy are closely linked in a relationship that is exacerbated by recession and pandemic. Public expenditures decrease, and service provisions may also decrease at a time when people need it most. When all members of the world are feeling vulnerable, people with disability may also experience a further heightened vulnerability to loss of dignity, particularly if they require formal support for their daily living. So now, what does that mean for this after COVID-19? Because I do still think we're in the during. The impact is going to extend well beyond the pandemic and may entrench long-lasting economic, social, and attitudinal barriers that will further limit people with disabilities' access to services and ongoing participation as citizens. Now more than ever, it is imperative to examine how dignity is experienced and understood by people with disability in order to disrupt the barriers to dignity, but also to promote what the community wants and hear from citizen-driven experiences. This will serve to ensure that all members of the Commonwealth of Human Dignity, which is our global society, are being treated equally and with dignity. Back to you, Michelle.
Thank you, Kelsey, and thank you for ensuring we're still close to time despite our beginning technical difficulties. I do have a question that's been posted for you, Kelsey. Could you just tell us briefly a little bit more about the Community Hub and how someone might become a member?
Sure. So the Community Hub is a private SharePoint group, and there are lots of links on the Hopkins Center website under the tab Dignity Project for people to fill out a form to join. Alternatively, you can just email dignityproject@griffith.edu.au and we can get you set up in there. The platform is for people with disability only, as it is a private and safe safe space, for people to analyze and share their stories. And every week or every fortnight, we are sharing from a number of our different moderators who are writing informative and insightful blogs to help share their experience with the community. We also post opportunities for people to become involved in research, either as a citizen scientist or as a participant. And yeah, there's more details on our website.
That's great. Thank you very much, Kelsey. And I'll look forward to seeing what the next steps are now that you've done some of that survey work.
Thanks.
All right. So to finish off today's session, we're going to bring you a new initiative, the Citizens Challenge, Designing for All, which is brought to you by our HabITec flagship project team. And for this, I'm going to hand you to Sally Stewart, who is the Hopkins Business Development Manager. Thanks, Sally.
Good afternoon, everyone. My name's Sally Stewart, and I too would like to acknowledge the traditional owners of the land on which I am today, the Yagara people, and pay my respects to elders past, present and emerging. HabITec is a flagship initiative of the Hopkins Centre focused on bridging the gap for people living with disability and technology. At HabITec, we facilitate the co-design of technology solutions as well as technology integration into practice solutions with end users. So that's people living with a disability, as well as health and rehabilitation practitioners. Too often, technology is not designed by or with people living with disability. And we know and see that this is the reason why technology often fails or excludes people. Today, I'm really excited to be able to share our new program, the Citizen Challenge program. It's designed to overcome some of these barriers. This opportunity arose when I met with Dr. Cara Burns from Queensland Health, who is an active participant in Queensland's growing health technology startup community. Through a Department of Science, Industry and Innovation grant, supported also by the Hopkins Centre, Cara has coordinated external and internal experts from diverse backgrounds to create this really well-structured online program. We want to share some of this with you today. So there is a video that will follow, and included in the video are some of the stories from our citizen participants, as well as from rehabilitation services. And it culminates in a pitch, and this is the third and final workshop in the program. So from our project team who helped create the Citizen Challenge program, and from the GoGo Innovators, the Citizen Challenge team, I'd like to ask you to enjoy this video. Everyone is watching online and here to answer questions if we have time at the end. Thank you.
Research Fellow at the Hopkins Centre, Griffith University, and this year I was the organiser of the Hopkins Centre Citizen Challenge. In my job at Queensland Health and in my research, I specialise in engaging and empowering citizens in digital health products and services. Through the Hopkins Centre Citizen Challenge, people with disabilities are able to co-create with entrepreneurs new solutions to their challenges. The Hopkins Centre Citizen Challenge was a three-part program where we were able to pivot existing offerings in the market to meet the needs of people with disabilities. This year, the challenge we focused on was how might we optimise technology to provide quality online rehabilitation services to promote customer choice and independence for our citizens.
Hi, my name's Lindsay Knight. I've got a spinal cord injury. I acquired that 27 years ago in a swimming accident on the last day of grade 12. Since then, I've been able to sustain full-time employment, been travelling, been able to live an independent life. I do rely on support workers to be able to help me out during the day. Without them, my life wouldn't be sustainable. Over the past several months due to COVID, my support services have changed, and that's across the board for everyone with a disability. We're having to go from being in contact with support workers, but also doctors and health professionals with regards to exercise physiology. For me, that's ranged from having phone calls with my GP down to having a Zoom meeting with my EP over the back deck with my support worker, mounting the phone so that we're able to do an exercise program and be able to make that challenge happen. We just improvise, adapt and overcome and get around it. So some of the challenges I have and I've always faced is having half a dozen support workers, and that can range through having that through my care agency and then having to manage that with their routine. But mine is normally a standard set roster, and in that we know what's happening, but there are times where circumstances change, and then over COVID you've got to be fluid in your decisions and being able to adapt to that when someone is unable to come, and so being able to work with the care agency and being able to work with them when they're working remotely from home as well. So there's always different challenges in using technology to be able to make that happen. So a goal would be to be able to have an app that would be user-friendly across the board for a range of people with disabilities. That could be someone with limited hand function, being able to have something that is user-friendly for someone with a vision impairment, a hearing impairment, making that easy to use for support workers, but also providing confidentiality across the board so that anyone who has access to that client's information can only see that for a small time frame, or you're able to share that through the relevant documentation or via telehealth to someone. As part of my personal support care, my personal life work, I have 2,000 hours of support that I need to manage, and that is also managed through an organisation that has over 500 clients. They need to support them on high needs and low care. Plus I have my own exercise physiology appointments, casual volunteering as well, and my personal life and family members I need to see. So that's quite a lot to involve in one person individual. So an organisation to have an app that would work would be awesome.
My name is Bill Peacock and I'm a survivor of polio. I became disabled at the age of 4 years of age and spent my entire life with a disability. In my late 50s, I ended up in a wheelchair full time because of disability, then had an accident causing me some spinal injuries to the lower part of my spine and across my shoulders. I have spent my life being educated to support people with a disability in the sectors of disability around Australia. In the last 12 months, I've had many difficulties trying to manage my aged care environment with the disability through telehealth and some of the systems that we have to have without facing somebody face to face. Going on to a Zoom meeting or to a telehealth meeting can become extremely difficult when somebody is not there to measure you for your new wheelchair, to be able to give you an opportunity to select the things that you need and to carry out your life with independence. Often when you're talking to a medical practitioner or to an allied healthcare professional, they don't always have the opportunity to know your background, your story, or your life. Often the challenges that I face personally, and most of the people that I speak with as an advocate, is that we don't often have the opportunity to be able to cancel an appointment and remake an appointment. Sometimes we find ourselves in a situation where a carer will not turn up on time, the carer is not available to you at a specific time. I'm very fortunate that I have a full-time carer, 24 hours a day, 7 days a week. And his role is often to make sure that I am being cared for in the way that I need to be. So he has the same challenges to face as well. We need often to be able to make 5 phone calls to get one appointment satisfied. So we tend to work closely together between carer and the person being cared for to make sure that we can live a strategic day. And sometimes that day is very difficult because we are not being met with the appointments that we need to, because a carer is running late, a shower is not going to be possible, and then we have a doctor's appointment to meet at the same time. Currently there is over 1 $1.5 billion of unspent funds in the my aged care sector, and that is important to be spent independently by the client.
Hi, my name is Beth. I'm one of the physios with the Spinal Outreach team. SPOT is a statewide service with Metro South and the Division of Rehab for people with a spinal cord injury. We're multidisciplinary with OTs, social workers, nurses, community registrar and our researchers. So some of the benefits of telehealth is it provides us the opportunity to see and meet with our client face to face without maybe being in their environment to help problem solve in that initial instance, whatever the clinical problem is that the person has come to our service about. The challenges with telehealth or a video visit can be just sometimes the technology fails, and that's the same with any of the platforms that we've had experience with, but often it works really, really well. I think also it's everybody having confidence to be able to feel that the visit's actually going to deliver, and that's from the health professional's point of view as well as from the client's point of view. Other challenges we've had would be that we can't actually see what we want to see. We can't maybe zoom out or zoom in if our client doesn't have someone with them that can help work the technology. So planning what's going to happen on that video visit we've found is really important, and that can really overcome some of those challenges and make the visit successful. I understand about the not being able to touch and feel and measure, trial things quite the same, but during COVID we really had no option but to try and problem solve, and we're trying to roll with all of the improvements that are out there both within the public and the private sector with telehealth and video visiting to be able to make this work for the long term.
We've got approximately 1,800 people with spinal cord injury that are either members or clients of our organisation, and they receive services that are allied health, personal care, peer support, employment support, and having an app that could assist them to be able to organise that would be just fantastic, and particularly if it's physically accessible for people, because there's so many things that make that people can be limited with if they've got hand function that's compromised.
Hi everyone, my name is Marley Brown and I'm the CEO and co-founder of Compago. At Compago we've been specialising in assistive technologies, particularly in the aged care sector, for the last 5 years. But today I'm here to represent the GoGo Innovators. The GoGo Innovators is a crack team of entrepreneurs which were put together by the Hopkins Centre with support of Griffith University and Compago. Now we were tasked with solving a pretty big problem. How do we optimise technology to provide quality online rehabilitation services while promoting customer choice and independence for those that are receiving care? Now, before we dive into the solution, let's first dig a little bit deeper into that problem. So there's over 400,000 people receiving NDIS support here in Australia, with 150,000 who have just recently joined and have had their first care experience. So this is a platform which is growing. And it's a large population worldwide too, with over 100 million people. Now, one of the key people that we've been speaking to here as a part of this program is Lindsay Knott. And Lindsay Knott, like thousands of others here in Australia, has suffered a spinal cord injury, and as such has had to overcome multiple challenges throughout his life. So the solution that we've been working on here with the GoGo Innovators, with Bill and Lindsay and the rest of the team, is how do we develop a system which enables community engagement, seamless video consultations, improves health and well-being for those that are using it, and improves operational efficiencies for the organisations that supply and deliver this care. The GoGo Innovators will develop a one-stop shop for NDIS providers and recipients to be able to not only receive and deliver care, recipients will be able to jump online, see what activities are happening within their local area, book those activities, and through seamless connections, have that billed directly from their care packages. The person who's set up that activity will be able to organise the appropriate transport and delivery to make sure that people are attending those physical activities safely. The individual will also be able to jump on the virtual community where they can connect with others through our digital mobility window to discuss world activities and things that they're interested in. They'll also be able to use this window as a one-touch telehealth solution, so they can communicate with their GP as well as their carers. Now, following the delivery of these services and touch points, the individuals will be able to rate their carers and the care experience with one touch, directly following any activity. Now, this will enable those high-performing organisations to be rewarded, as they'll be moving up in the scale and receiving a higher Net Promoter Score. Now, there's vast benefits for the broader community as well, through increased activity and the opportunity for not-for-profits and smaller organisations to market these activities within the platform as well, as a low-cost alternative. Through tracking performance, high-performing organisations will be rewarded, and efficiencies will be found through lower administration costs for those who are wanting to receive care and those that are delivering it as well, ensuring that more funding goes directly to the care recipient and isn't held up through administrative burdens. Now, it's essential that a platform like this has seamless integration. So utilising Compago's middleware technology, we'd be able to integrate a system like this with existing staff management and rostering platforms. So all you'd have to do is turn on this platform. The data would automatically be generated from any client within your database. Through connections with partners like Medipass, we're able to organise payments through this system, and also through connections with other community organisations, they'd be able to use this as a platform to broadcast content that they've developed locally without having to go through expensive media channels. Now, a platform like this really has limitless possibilities. We can integrate this with wearables so that individuals have their vital statistics tracked. We can also integrate it with smart home technology so that through this tablet, just by clapping their hands or even winking, they can turn on the lights, open the door, and once you start integrating robotics technology, they can order a drink through the same means without having to organise their carers. So the ask of you all is, this is a system that's really not that unachievable. We've built a vast majority of this already. We're utilising it in the aged care sector. So what we're looking for at Compago is partners in the NDIS space who'd be interested in trialling this technology and helping us to develop it out further to further meet the needs of this growing demographic. Thank you.
My name is Justin. I am a Citizen Ambassador at HabITec and at the Hopkins Centre. I'd like to say thank you and congratulations to the Hopkins Centre and the Citizen Challenge team for all their work and allowing me to be a part of the Citizen Challenge Pivotathon project. It's been interesting and very informative for me to see the Citizen Challenge project development from behind the scenes, as well as all the organisation and planning required. The use of Microsoft Teams to meet and communicate has been quite accessible for me to participate from home, which has been a big relief due to the COVID risk. Here are a few points of why I think the Citizen Challenge Pivotathon format can be effective in playing a significant part in achieving the goals of inclusive co-design and sustainable solutions that HabITec has set out to achieve. It allows developers to better understand and design around the potential obstacles faced by end users, while also allowing end users to see the possible technological or budgetary constraints a developer might face. This, combined with the experience and expertise of the clinicians, creates an environment which encourages empathy between all parties, resulting in more useful and effectively designed assistive technology. The constant and open live feedback allows potentially vital changes to be made during the important design stages, rather than after the product has been approved, advertised, and put out on the market, only to be left aside by the target end user due to some easily overlooked design flaws. By having the three main stakeholder groups work together cohesively in a comfortable environment, while also under the pressure of having a limited time frame, helps to accelerate the development process in a more engaging and motivational manner, which makes it feel more like fun than work, resulting in an overall more enjoyable experience for all parties involved. I also think that in future, when the project grows and involves multiple teams, engagement and motivation can further be boosted by introducing and providing some friendly competition between the teams, and also a prize incentive to be awarded to the most effective solutions. Thank you.
Well, thank you very much, Sally, and the HabITec project team. And I endorse Jason's comment there and congratulate you on bringing such a great initiative. Unfortunately, we don't have time for questions of the team, but we welcome you posting them and we'll get them to the team. Or if you want to connect indeed with any of the speakers today, you're welcome to do that through the Hopkins Centre at griffith.edu.au. And also there'll be, look out for more Citizens Challenge in 2021. So that brings our second session to an end today. I'd like to thank all our invited speakers and presenters for sharing their insights and particularly for sharing the ways they are working with citizens with disability to be more inclusive in planning and decisions, and to promote and protect the rights and dignity of people living with disability. And I'm hoping that that is conscious raising for all of us as we go back to our places of work and communities. Thank you to everyone who joined online for today's Hopkins in Focus event session, and I trust you found that stimulating and informative, and please keep questions coming and contact with our speakers today. Thank you to our sponsors, Cisco WebEx, Telipa and Bebrick. And as mentioned before, we did record it and we will forward all of the recording and details and responses to you in due course. Thank you for your patience with the technical issues today that we got through in the end. If you haven't registered for the third and final event, please do so. I encourage you to do so on the Hopkins Centre website. This will be a panel discussion, a panel Q&A with some of our leaders and visionaries in disability and rehabilitation who are going to be looking to the future, and that will be facilitated by futurist and commentator Morris Maslowski. So don't miss that, please register. So thank you again for joining us and do have a good week. Goodbye.